So, maybe there will be a day, couple of decades down the line, when you could do an MR and get some microbiology as well. But currently, radiologists and orthopedic surgeons and spine surgeons and everybody, I don't think we are able to see organisms, on the MRI films currently. So until that happens, no focal bone or spine lesion should be treated empirically without a biopsy, unless a biopsy is absolutely not possible or the patient needs emergency surgery. Let's say there's a spine lesion, patient's acutely paraplegic or quadriplegic, and you have to go in to remove that obstruction, then that's fine. But apart from that, there is no justification for starting any form of treatment without a biopsy. So look at this 41-year-old. You've got a classic L1-2 discovertebral lesion. There's a paraspinal lesion. There's a psoas lesion. And you'd say, okay, this looks like TB unless proven otherwise. I've put in a needle in the psoas abscess, aspirated plus, and this was TB, rifampicin not resistant, culture positive. And this is your standard case that you would see. But here's another patient, right? 26-year-old Indian studying in the US on vacation in India. He's been there only for 2 years. Comes up with a classic discovertebral lesion at L5S1. You've got a paravertebral collection, etc. I went in and biopsied the sacral alar lesion because that seemed to be the best to give us material. This turned out to be coccidioides immitis. And that's something that you get in Arizona. I remember Camila calling me and saying that this patient has coccidioides, but I cannot give the diagnosis to an Indian patient. And so we called the patient, and it turned out that for 2 years the patient had studied at Arizona State. And that's the hotbed of this particular disease. And there is no way we would have known this without having done a biopsy. So if we look at literature, you'll always find papers, textbooks, talking about classic findings of infectious spondylitis, and then various ways of differentiating pyogenic from tuberculous infectious spondylitis. And most of my talk will be on spine, and you can just extrapolate the same thing to the joints. And the latest paper that came out early this year, which was a meta-analysis, kind of said, okay, if you find all of these things, then it's TB. If you find these things, it's pyogenic. But the questions that come up on a regular basis in practice are these, and we'll try and answer these. In an individual patient, irrespective of whatever the findings are, in that specific patient in front of you, is it possible to know for sure whether the patient has TB or not? And I'll show you some examples. This is an infectious spondylodiscitis at L5S1. You've got a classic discovertebral lesion, some perivertebral soft tissue. Went in and biopsied it, and this is Acinetobacter. And I've been learning new words now that I've been doing these biopsies, because a lot of these organisms didn't exist when I was doing my microbiology in the mid-80s. Here's another one. Younger patient has L5S1 infectious spondylitis or infectious discitis. This, when I biopsied, turned out to be Salmonella paratyphi. This one looks like classic TB, D2-3 infectious spondylitis, abnormal soft tissue, everything's there. Biopsy, brucellosis. And this is through the disc and the end plates with a transpedicular approach. So that's the answer to your question. So let's say that we're 100% sure it's TB. All right? Classic large psoas abscesses, 25-year-old. There's no doubt. Even then, is it possible in an individual specific case to say whether that TB is resistant or not to rifampicin, right? So here's this 19-year-old classic TB, large psoas collection. In this case, I only went into the psoas collection, and this is TB naive, right? First time that the patient has ever presented with TB, INH and rifampicin resistant disease on PCR, LPA, and culture. Right? So there is no way to know by just looking at the MR whether the TB, if it is TB, is going to be sensitive or resistant. The next question is, how much material do we take and for how many organisms, right? So even if it looks like TB, right? You've seen TB spine cases for the last 20, 30, 40 years. You know this can't be anything else. But at the same time, when spine surgeons like Samir write down a prescription, it's going to be for AFB, PCR, culture, aerobic, anaerobic, fungal, and it doesn't end, right? If it's pus, you can do all the tests on them, but if there's only tissue, then how much tissue do you remove to be able to do each and every test? But look at this 76-year-old, multifocal disease, there is an infectious spondylitis here, there's perivertebral collection here, pus we aspirated, it turned out that the patient had TB, but the patient also had staph hemolyticus on the same sample, right? How would we have known in the beginning, first of all, what this was going to be? It could be TB, it could be pyogenic, and this patient has both in the same sample. It's kind of got a multifactorial, multibacterial disease. Then the question is, if you can have so many things happening, you have these newer tests that have come up, such as BioFire and 16S rRNA. Should you send for all of these as well? Here's a 63-year-old, got D12L1 infectious spondylitis, classic discovertebral, perivertebral collection here, did a biopsy, transcostovertebral into the lesion. It's Acinetobacter baumannii, culture positive, 16S rRNA positive, everything else negative. And I'm sure in the next panel discussion, these things may get discussed. This is an 89-year-old infectious spondylodiscitis. An MR was done way back then, everything happened on PET. That's because patient is South Bombay. And in South Bombay, you do the latest, the gradient, right? From Sobo to Borivali. So somewhere in Dadar is where you get optimum treatment. But anyway, you got the gist. So we had 2 PET CTs tracking the infectious spondylitis here. That's the CT, and it was rapidly progressing over 6 to 8 weeks. So, clinically almost definitely pyogenic, non-TB. So you knew you had to take material for a lot of stuff. So this was Citrobacter positive on BioFire. So it's kind of urosepsis into the spine, but culture and 16S rRNA negative. And the question then remains, how much material do we take for what? And so then the question is, forget TB. So the questions I've asked so far is, in an individual patient, can you differentiate TB from non-TB? Can you say whether that particular TB is sensitive or not, etc.? But can you even differentiate TB from other things or infection from other things just on the radiology and the clinical examination? So here's a 34-year-old, multifocal disease, multiple vertebrae involved, there's SI joint involvement, there's some scapular involvement. Patient was put on TB empirically. Repeat MR done after about 5 months actually shows that the spine lesions may have improved a little bit. There's a sternal lesion reported as collections in the pre- and retrosternal region. And this is the sacral lesion where some of these have regressed and some of these have come up. Possibly the patient was also given steroids along with the anti-TB treatment. Then there was further progression, and now the sternal lesions really become big. Went and biopsy done, that was non-Hodgkin's lymphoma. And while we could say that perhaps the radiologist and the orthopedic surgeon treating may not have had the expertise and experience to, at the first instance, perhaps straight away get a biopsy done or think this could not be TB. This is a story that occurs in every second patient across the country anyway, right? Where we mistake other etiologies for tuberculosis or some other infection. The reverse also happens. So this is an 80-year-old who has this complex malignant parotid mass, and for good reason a PET CT has been done which showed this lesion, then the MR showed this here. And so clinically, your first thought is this should be metastatic disease. We went in and biopsied it, and it turned out to be PCR and culture positive tuberculosis, at the same time having come up as the malignant parotid lesion. So unless you biopsied this, you would say this is metastatic parotid carcinoma. The treatment is completely different from a non-metastatic parotid carcinoma. So the biopsy was so important in this to establish what it is. And the next one, this is again primarily for orthopedic surgeons because you're so quick and fast and you want answers instantly, etc. Is there a role for patients in today's day and age, or is that an outdated concept? And this question also goes to all the microbiologists and the infection disease specialists as to how can we speed up the ability to get an answer on culture, right? So here's a 22-year-old right hip pain. MR shows unilateral sacroiliitis. CT was done, showed this focal osteolytic lesion with the central thing, which is a sequestrum, but was mistaken for a nidus. So the initial thing was patient has an osteoid-osteoma. Can you RFA this? They came in, I was quite sure this was not an osteoid-osteoma, but I said, let's just biopsy it. Took a lot of convincing to get this done. But finally they agreed, did a biopsy. Gene expert was negative. But the histopath did say granulomatous inflammation or infection of possible mycobacterial origin. The infectious disease specialist wanted a repeat biopsy, rightly so. But I said, we've sent for culture. How do we justify a repeat biopsy? Then why send for culture? If we are going to say that a negative PCR means a failed biopsy and therefore we should go ahead and repeat the biopsy, then what was the point sending for that 3 and 4 and 6 weeks culture? So with this logic, they said, okay, we'll wait. And they waited, and the 4 weeks culture was positive for MTB. Everything negative. PCR negative, histopath plus minus, and sometimes on histopath you can see AFB as well, which many of the pathologists report. None of that, and only culture positive, and then the patient improved. So the question that follows is the same one, that when PCR and other cultures are negative, but histopath rules out malignancy, do we wait for the culture reports or do we rush in and repeat a biopsy? So last month, something very interesting happened. There were post-op spines, not really relevant here. Post-op spine infections, biopsied them, everything negative in the first week, and both patients were operated because they said everything's negative. And the 10th day, the fungal reports came positive. But the point is, nobody wanted to wait, including the patient, because the patient also says, "Mere ko dard ho raha hai, aap log kuch nahi kar rahe ho," and then you're pressurized into operating. Lastly, whose responsibility is it to communicate the results of the culture report so that the patient can pay for and give permission for sensitivity testing? And I'll tell you why this is relevant. And this happens about once a year. 23-year-old unilateral sacroiliitis, biopsied the patient, PCR positive, rifampicin resistant. So the patient is put on treatment. Patient was giving NEAT. So went back to her village in UP, studying for the NEAT. The 6 weeks culture report came positive. But there was, the patient thought that the physician will take care of it. The physician thought the orthopedic surgeon will take care of it. By the time all the communication happened and the patient was told that you need to pay for sensitivity testing and get it done, it was about 10 days and the samples were no longer available for sensitivity testing. Patient comes back 4 months later, everything's progressed significantly, go ahead and re-biopsy this. And the re-biopsy is for what? Only one reason, that we need material for the culture. That will take another 4 to 6 weeks, so that on that sensitivity testing can be done so that the appropriate treatment can be started. And that's about 40,000-50,000 rupees completely down simply because of a communication problem. So I don't have an answer, but clearly somewhere people are falling through the cracks. And like I said, happens once a year. It's happened twice to doctors themselves who were patients. And where this happened, so clearly it's an issue related to logistics. So the questions that I asked and the answers to those, it is not possible in an individual patient to differentiate non-TB from TB infections. You can have a pre-biopsy kind of diagnosis, elderly patient, 75, no large abscess, you would say this is likely to be pyogenic. It is important because the amount of material you take and send for other tests, it matters. If you don't get pus, you have limited material, and then how do you decide how much goes for what? And today, when for suspected pyogenic, we're also asked to take material for biofire in 16 hours. So think about it. If it's only tissue, right? You don't get pus. It's PCR, sometimes LPA, sometimes culture, then fungal, aerobic, anaerobic, and now biofire in 16 srRNA. That's 8 cores only for micro, plus 2 to 3 cores for histopath. And sometimes there isn't enough material in that patient. You've pretty much removed everything by the time this exercise is completed. It is not possible to differentiate resistant from non-resistant TB on any imaging modality. So you do need material every time for this. It is possible for patients to have dual organisms, and hence it is important to test for multiple organisms, irrespective of what our pretest probability it is. It is often not possible to differentiate infection from tumor and other etiologies, so you need to biopsy. It may not be a bad idea to wait for culture reports before a rebiopsy, and it is important to make sure that patients don't fall through the cracks for sensitivity testing on culture reports. So I come back to my original slide. No focal bone or spine lesion should be treated empirically without a biopsy, unless a biopsy is absolutely not possible or the patient needs emergency surgery. So the one question I didn't answer is, when is biopsy not possible? And that's usually in the OC1, C2 or CVJ area, where sometimes if it's an anterior lesion touching the vertebral artery, perhaps it may be a little tricky, but that's typically once in about 2-3 years that we face that problem. Otherwise, every spine lesion, every bone lesion can be approached and can be touched. So I just wanted to plug my book. This is a non-radiology book that I've written, available on Amazon. Thank you so much for listening to me.